Hello guys, first of all thank you for loving this series so much, your high yield revision series. So I think those who have watched the first video they know what this MTR is. So मुझे तो रटो. So this is like the BTR session which Janam ma'am conduct, that is बुरी तरह रटो session. So now see, in this we will see some of the clinical hints that will help you identify the answer. We'll also be seeing some images that may come in your exam. So let's get started with the high yield revision series part 2 MTR2. So see, when we talk about if the clinical hint states like this all the F, fertile female fat in their 40s, fair looking, so this point towards your cholelithiasis, that is the formation of the gallstones. So we have pigmented gallstone and non-pigmented gallstone. Just have a look at the difference. Now see, when you have a painless jaundice with your enlarged gallbladder, so that is basically the cancer of the pancreatic head. Then bluish line in the gingiva, guys, look at the photo, this bluish line. So this is known as the Burtonian line. This is the bluish line, and this is seen in your lead poisoning. So now the question that may come, guys, okay, what are the clinical features of lead poisoning? So which of the following is not? So A, anemia, okay. Then we have B, basophilic stifling, C, colicky pain. We have D, wrist drop, foot drop. E, encephalitis. F for facial pallor, which is the earliest sign, which is again a MCQ that may come in your exam. Which is the earliest sign in your lead poisoning? That is your facial pallor. This is the earliest sign. Okay, so and this is the Burtonian line, which we have already done. Bluish line on the gingiva. Now coming on to the next one, that is if the question suggests you have a short stature, okay, with the presence of a short stature, so you have a cafe au lot spots, okay, so that suggests neurofibromatosis, guys. But you see, we have a thumb or radial defect and increased incidence of tumors. The most important that is your Fanconi anemia. Okay, and this Fanconi anemia, there is a defect in DNA cross-link repair which often progresses to acute myelocytic leukemia. So remember this Fanconi anemia, again an important MCQ. Now you see, the RBCs are fragile and you have red pink urine, so paroxysmal nocturnal hemoglobinuria. So what are the things you need to know about this PNH? Okay, so we have two genes that are defective. One is this CD55 and one is this CD59. Okay, so this CD59 is known as your decay accelerating factor, and this CD59 is known as your MIRL, that is your membrane inhibitor of reactive lysis. Okay, this is the only acquired defect, guys, that you need to know. See, so how do you remember CD55 is CD55 is DF, D fourth letter, A first letter, 5, that is 55. So don't confuse, guys. Okay, PNH, again a potential MCQ. Now see, guys, again the history suggests you hemolytic anemia like the PNH wala history, okay, that was acquired. And here you have a painful blue finger or toes, guys. So this is basically a autoimmune hemolytic anemia. Okay, this is cold wala thing. So we have two things, warm and cold. So warm is garam, so the antibody is IgG, G for garam, and cold the antibodies is IgM. Again a very potential MCQ. This is caused by mycoplasma pneumonia or infectious mononucleosis. This is again a potential MCQ that may come. Now see, when you have petechiae, we have bleeding and prolonged bleeding time, guys. Okay, so each of these findings suggests towards some bleeding disorder. So see, we have platelet disorders like Glanzmann thrombasthenia, Bernard-Solier. So what are the defects that we see here, guys? Okay, so Glanzmann thrombocytopenia is GP2B3A, that is CD4161 defect, and Bernard-Solier, that is GP1B9 defect. So this is your Bernard-Solier. So what is the thing that you need to remember? Bernard-Solier, B for Bernard, B for Bara platelet. Then coming on to this hemolytic uremic syndrome, guys. This is caused by E. coli, enterohemorrhagic E. coli. And what is the strain, guys? That is O157H7. Strain of this E. coli. You can have thrombotic thrombocytopenic purpura or your immune thrombocytopenic purpura. All these bleeding disorders wala thing, platelet ka disorder. Now see, classical triad, fever, night sweat, weight loss. What is this? Is the classical triad of lymphoma, that is the B symptoms, guys, of the malignancy. Then see, you have Portreous microabscess and you have atypical cells. So guys, see, there are two abscesses that are very frequently confused. One is this Portreous microabscess and one is this. So see, when it is Portreous microabscess, guys, P is not for P. So Portreous microabscess is seen in Mycosis fungoides. Okay, Again, and you have one more microabscess, that is your Monroe's microabscess, which is seen in psoriasis. So you see, P goes with M, and okay, so Potter's is for mycosis and Monroe's is for psoriasis. Again, a potential MCQ that may be tested. Now see, neonate, you have a difficulty following the birth, means there was a problem in delivering the shoulder, so it may be as a long stem question, so the child looks like it is in waiter tip position, so that is your Erb's palsy, guys. Okay, look at this Erb's palsy, guys. So there is damage to C5 and C6 nerve root. Okay, the child may present with Horner syndrome, and this is the classical deformity that is known as your waiter tip deformity. Now see, anterior drawer side, A for anterior drawer, A for anterior cruciate ligament injury. Then see, we have bone pain. Bone has become enlarged and there is arthritis, means there is defect in the formation, that may be termed as osteitis deformans, and like Paget's disease of the bone, where there is an increase in osteoblastic activity and the osteoclast. So osteoblast basically form the new bone and clast basically cuts the bone. Okay, that decreases the bone formation. Now see, you have a swollen, hard, painful nodules. Okay, like this is the photo. Swollen, hard, painful nodules, and that pain worsens with activity. Okay, as you do work, guys, pain will worsen. So that is rheumatoid, that is osteoarthritis, guys. Also, you may have a question of rheumatoid arthritis, guys. So what is the differentiating features? With activity, pain decreases, guys. Okay. Here with activity, pain increases. So again, an important differentiating factor. Why, guys, it decreases in osteoarthritis? Because osteoarthritis is due to the wear and tear. So when you work, there is more wear and tear. Rheumatoid arthritis is due to the accumulation of rheumatoid factor. When you do some work, this factor gets washed away, hence reducing the pain. So this is again a classical history. See, osteoarthritis, you have two things. One is this Bouchard node and one is this Hubbard node. So remember, B is like this P. Okay, so this Bouchard node is the proximal interphalangeal pair, it's there, and for distal it's Hubbard node, DH. Okay, remember it like this. Again, an important MCQ. Now see, if the question suggests something like this, that is swollen, painful big toe, so generally the first metatarsophalangeal joint and this aggregations are known as the toe phi. So this gout also known as the podagra, and this is due to hyperuricemia. Come, let's revise some pharma also. So what is the enzyme that converts hypoxanthine to xanthine, guys? Okay, there is an enzyme known as the xanthine oxidase. So we need to inhibit this enzyme so that uric acid production decreases. So we have a drug known as the allopurinol. Also, we have one more drug, that is the febuxostat. In name, axo is coming, means this is a xanthine oxidase inhibitor. Also, we can have drugs like allantoin or new drugs like rasburicase. So these are the drugs for your gout treatment. Now see, we have dry eyes, dry mouth, the classical symptoms of Sjogren syndrome, which is an autoimmune disease, and here the exocrine glands destroyed. As a result, there is a decrease in secretion. Now see, you have reactive arthritis, guys. Okay, so reactive, remember conjunctivitis, urethritis, and I have remembered it as periarthritis. So I have remembered as reactive cup. So this is associated with HLA-B27. So what are the other things that is associated with your HLA-B27? That is your Peyer's mnemonic. Or okay, P for psoriatic arthritis, A for ankylosing spondylitis. Okay, this is your psoriatic arthritis. This is your ankylosing. I is for inflammatory bowel disease, and this R is for Retter's syndrome or the reactive arthritis. Okay, again a classical MCQ. Now see, butterfly face shaped rash. I think this gives you a, and this butterfly face rash. Okay, this SL is systemic lupus erythematosus. So it is more common in young female. And what is the criteria, guys, that helps in diagnosis? That is your Euler criteria, where we have 4 out of 11 criteria: serositis, oral ulcer, mucosal ulcer. You have autoantibodies, anti-Smith antibodies, antihistone antibodies. Then you have the blood vessel involvement. There are many criteria. So systemic, it involves almost all the organ. Lupus, because this looks like a wolf. Erythema, red. Okay, so this increases on exposure to sunlight. So again a potential hint that may be in there in your question. Now see, you have cervical lymphadenopathy, you have rash, coronary artery aneurysm, you have your means mucosal ulcer. So this is, guys, this is your classical history that you see in your case of Kawasaki disease. So see, Kawasaki disease, you can have red color tongue, which is known as your strawberry tongue. So there are two diseases for strawberry tongue. One is your Kawasaki disease, one is your scarlet fever. So what is your this diagnosis criteria, guys? Okay. So remember, with the help of mnemonic cream, C means you have conjunctivitis, R means rash, E means edema, okay, A means adenopathy, cervical adenopathy, often unilateral, M for mucosal involvement. So you should have 4 out of 5 criteria and you should have fever for 5 days. Look it out, guys. Cervical lymphadenopathy and this coronary artery aneurysm, okay, that is the most common cause of death. So this is the basically known as the mucocutaneous lymph node syndrome. Again, a classical MCQ. I think you might have heard in your COVID time, this disease increased when there was a COVID, okay, and this is treated with your intravenous immunoglobulin and aspirin. Again, a potential MCQ. Now see, when you have a palpable purpura, abdominal pain and hematuria, this is your classical trait that you see in Henoch-Sonnlein purpura. That affects, there is a deposition on the skin, guys, so that is palpable purpura. And kidneys, that is your hematuria, that is your IgA vasculitis. Now see, when there is a change in color, okay, when you have cold or stress, guys, okay, so normally the fingers appear pink, guys, okay, so that will appear more blue. That is your Raynaud phenomenon, that is there is a vasospasm, decrease in blood flow to the extremities. Now see, when you have a dark purple skin, mouth nodules in a patient with AIDS, this is the classical photo that every time they show you, guys, okay, so this is just seen in your AIDS patient and this is caused by human herpes virus HHV8. Again, a potential MCQ that may be tested. So this is a potential MCQ. This is again a potential MCQ. This Erb's palsy, again a potential, and this one, this Monroe's wala, again a potential MCQ. This Glanzmann and all, they can ask you in the match the type question wala thing. Okay, now see, coming on to if they ask you this type of lesion, guys. So when you look at this lesion, guys, so you remember the presence of P's, guys. That is, you have purple, pleuritic, okay, see, purple, pleuritic, polygonal, planar, papules, plaques, okay, so this type of lesion that is seen in your lichen planus. Again, an important question. Now see, when you have a truncal ataxia, okay, so ataxia, nystagmus, head is tilting and you falls toward the injured side. So cerebellar ataxia, there is a same side fall. So this is the cerebellar lesion. So for cerebellar lesion, we have a mnemonic known as this Danish mnemonic. Okay, D is for dysdiokinesia. So what is dysdiokinesia? That is alternate supination and pronation. Can you do it here? D for dysmetria, that is problem in coordinating. A, ataxia, inability to walk. And for nystagmus, I for intentional tremor. Okay, so this intentional tremor, when you start to do some work, that is intentional, and with Parkinson it is at the rest, that is known as your pill rolling tremor. Again, a potential MCQ. Then S for scanning space, slurred space. H for hypotonia. So all of these are a potential MCQ. Now see, when you have a dorsiflexion of last toe with fanning of other toe, okay, so that is seen in your upper motor neuron lesion. So remember, upper motor neuron, okay, everything is increased, so there will be increased tone, there will be extension of this toes, okay, so everything is increased. And while in lower motor neuron, tone is decreases, there is atrophy, muscle wasting, so everything decrease in your LMN and everything increase in your UMN. And this is, see, Babinski sign. So how, check it out, how Babinski sign, this is elicited, okay guys, this is eliciting the Babinski sign, okay. So how do we elicit? This is negative when you have flexion, and if it goes up, that is your positive Babinski sign, that is your upper motor. So this negative is the normal thing that we see in us, and this is the abnormal finding. Now coming on to the next one, okay, that is your, see, if there is a trait presenting like hyperphagia, hypersexuality, hyperorality, phasia, he is eating more, hypersexuality, he is more sexual, okay, and hyperorality, he has inquisitivity to put everything into the mouth and know, that is known as your Clever-Bushey syndrome. That is due to bilateral amygdala lesion. So if you have 3H, hyperphagia, eating more, sexuality more, and putting everything in my mouth, hyperorality, that is your Clever-Bushey syndrome. Now see, resting tremor, okay, you have, guys, athetosis, chorea. So all of these are basically movement disorder that are seen in your basal ganglia lesion. Now see, you have ipsilateral Horner syndrome, okay, you have dysphagia, means problem in eating, pain while eating, hoarseness of voice. So this basically looks like 9/10 nerve ka involvement, and you have your Horner syndrome, guys. So 9 10th nerve involvement. See, first of all we'll look at the rule of the 4 so that it helps you know. Okay, wait a second guys. Okay, so see, this is the rule of 4. So what does this rule of 4 tells you guys? Okay, so basically 4 of them arises from the midbrain. First and second we leave, third and fourth oculomotor trochlear. Okay, that is from midbrain. Now see, rest 4 is from pons. We have three structures in your brainstem, that is your midbrain, pons and medulla. So first 4 from midbrain, next 4 from pons, and last 4 from medulla. So medulla, that is 9 10 11th and 12th. Okay, now coming to on to the next rule of 4 guys. Okay, so in the midline we have 4 structures. Medial structure, that is M means you have motor tract, that is your corticospinal tract. If there is a paralysis guys, that is contralateral hemiplegia. Now see, you have medial lemniscus, that is a dorsal column medial lemniscus pathway, वो fasciculus and gracialis vulcunatus वाला pathway. So there is a opposite vibration and proprioception, means contralateral position and vibration sense का loss. Now see, medial longitudinal fasciculus, okay, that is for looking at the eye वाला thing, and motor nuclei of cranial nerve. So all the cranial nerve that are divisible by 2, like 3, 4, 6, 12. So this lie in the midline guys. Okay, so what are the cranial nerves that will lie on the side? That is 5, 3, 4 is there, 5, 6 is there, so 7, 8, 9, 10, 11. So these are the cranial nerves that lie in your lateral side. Now coming on to the side structure. So side, sympathetic chain. Do you remember in our question we have sympathetic chain ka involvement, Horner syndrome. We have ataxia, same side ka ataxia. We have spinothalamic, that is contralateral pain and temperature, and sensory cranial nerve 5. So this was about your rule of 5. Okay, so let's simplify this rule of 5. Okay, sorry, I did not include that diagram, it's fine. Okay, so this is your rule of 5. So see, coming on to our syndrome, that the syndrome per se that we had. Okay, so what did the syndrome show? See guys, you had dysphagia, means 9th 10th nerve involvement, gag reflex, nystagmus, and ipsilateral Horner syndrome. So this point out toward your lateral medullary syndrome, also known as your Wallenberg syndrome. So what happens in this syndrome? So you will have nystagmus. Okay, you will have ipsilateral ataxia, already done guys. You will have contralateral face paralysis. Okay, ipsilateral face and contralateral trunk and limb paralysis. You will have dysphagia, dysarthria, hoarseness of voice. Okay, and ipsilateral Horner syndrome. Do you see guys all the syndromes? So this is known as your lateral medullary syndrome or the Wallenberg syndrome, and this is due to pica, that is your posterior inferior cerebellar artery collision. Again a potential MCQ that may be tested. Okay, similarly we have the middle medullary syndrome, that is also known as the de-Journès syndrome, that is due to the anterior spinal artery involvement. Now see, when you have a lucid interval following a traumatic injury, that is your epidural hematoma, which is due to the rupture of middle meningeal artery, that is a branch of maxillary artery. If the patient describes it as worst headache of my life, that is your subarachnoid hemorrhage. Again a potential MCQ. Okay, so we have many types of headache: tension headache, cluster headache. Remember, only one headache that is more common in male, that is your cluster headache, is more common in males. And this tension type headache, this is the most common type of headache. Again a potential MCQ that may be tested. Now see, you have a resting tremor. Okay, you have rigidity, akinesia. Okay, you have postural instability, shuffling gait. Okay, micrographia. All of this point toward your Parkinson disease. Okay, which is due to the degeneration of your dopaminergic neuron in the substantia nigra pars compacta. Give a very probable MCQ that may be tested upon. See, this lateral medullary, again this is a potential MCQ. Now see, you have chorea. Okay, that is movement disorder. Dementia means memory loss, and caudate ka degeneration. So remember this Huntington disease, this is due to your trinucleotide repeat disorder. So what is the trinucleotide repeat? That is CAG. So how will you remember? A hunter uses a case, that is CAG ka repeat. Okay, so see, so what this CAG will also give you one more hint, that is C means there is caudate ka atrophy. Again a potential MCQ, this caudate degeneration. A means there is decrease in acetylcholine level, and G means there is decrease in your GABA levels. Okay, which is the inhibitory neurotransmitter. Again a potential MCQ. Now see, when you have urinary incontinence, when you have gait, okay, and when you have cognitive dysfunction, that is your dementia. Okay, so that is your guys normal pressure hydrocephalus. This is also known as your Hakim stride or your Adam stride. Both of them are the same name. So how will you remember this? Okay, so how I have remembered this national highway. Okay, NPH I remember like as a NH, national highway. This serves as a guide. Okay, when you go. So G is for, guys, see. Just UI is for urinary incontinence. Okay, then D is for dementia. Okay, and G for gait abnormalities. I think this helps you remember it. Now see, seeing the term multiple sclerosis. So what are the findings in multiple sclerosis? That is nystagmus, intention tremor is seen, scanning speech is seen. Okay, this SIN, okay, this classical triad, scanning speech, intention tremor and nystagmus, they are a part of Charcot triad which is seen in multiple sclerosis. Again a potential MCQ. So and you have bilateral internal ophthalmoplegia. So how will you remember this multiple sclerosis? Let's see, guys. This multiple sclerosis, does it sound like MS? Okay, does it sounds like US? That is, it's almost similar. So US, Donald Trump. So let's remember by the mnemonic Donald Trump. D for, it is a demyelinating disorder. O means in CSF finding you have oligoclonal band, and they ask you which disease is associated with optic neuritis. Again a potential MCQ. That is your multiple sclerosis from your opthal knowledge. Then there is a close differential diagnosis, that is neuromyelitis optica. This disease is due to autoimmune etiology. L means Lhermitte sign. So what happens? There is a transient shock like when you flex the head. Okay, so there is a shock line running down the spine. That is your Lhermitte sign. Then D for Dawson figure. When you look at the MRI, guys, okay, so you will have projection going inside. That is known as your Dawson figure. T means triad, that is your Charcot triad, SIN. Scanning speech, intention tremors and your nystagmus. Okay, resting tremor is in Parkinson, guys, do not confuse. R means relapsing remitting type, which is the most common type. U means Uthoff phenomenon, guys. Okay, so this gets worsen when you have a fever, hot bath, exercise, anything that increases your body temperature. Then M means McDonald criteria. That means there is a dissemination in time and space. The classical line the Harrison states. Then P means patency, like a latency of the nerve. So there is an increase while doing your auditory and sensory evoked potential. So this is so now let's revise. D for demyelinating disorder. O for oligoclonal band and optic neuritis. N for we have a close differential, that is neuromyelitis optica. A for autoimmune. L for Lhermitte sign, shock like wave down the spine when you try to flex. D is for Dawson figure seen on MRI. Then T. T is for triad, that is Charcot triad, that is SIN, scanning speech, intentional tremor, nystagmus. R for relapsing remitting type. U for Uthoff phenomenon. M for McDonald's criteria. And P for patency, that is the latency. Also see, let's complete this page. Okay, so this is the common poisoning and their antidote. So see, if someone asks you what is the antidote for your malignant hypothermia, so name NANT is coming. Okay, so the answer is DENT, that is dentrolene. Again a potential MCQ. This is the most frequently what is the antidote in atropine poisoning? That is your atropine. Okay, I think you know. Then see, warfarin, that is your vitamin K. Vitamin K is responsible for the clotting factor. What are the clotting factor, guys? That is 2, 7, 9 and 10. Now see, tricyclic antidepressant, that is TCA. So here it is like bicarbonate, sodium bicarbonate. Again a potential MCQ that has been tested, that is your cyanides. Okay, so what is there in cyanide? That is your amyl nitrate. You have dicobalt editate. Okay, sodium nitrate. Okay, these are your antidotes for it. Then this is again one of the most tested. This benzodiazepine is treated by flumazenil. Again a potential MCQ. Methanol by ethanol. Again a potential MCQ. Also it is by one more drug that is known as the formipizole. Again one of the most tested question. This is again a PYQ. Beta blocker, it is glucagon. Okay. Now see, iron, that is D-ferroxamine. Again a potential MCQ. This one, paracetamol toxicity, that contains acetaminophen. It's an acetylcysteine. Again, digoxin, we have an antibody that is known as the anti-digoxin antibody FAB. Other name for this is Diziband. Again a potential MCQ that may be tested. Then see, lead, that is ADTA. Copper, that is penicillamine. Okay. Mercury, that is your dimercaprol. name only mercury is coming. Amphetamines, that is your ammonium chloride. Carbon monoxide when is there, so we need to give more of oxygen, that is your 100% oxygen. And this phenothiazine, that is diphenhydramine. So I think out of this, guys, one questions definitely come. Okay, so have a look at it. This is very important, poisoning and antidote. Now see, when they say you have a rapidly progressing limb weakness that ascends up, okay, and following a GI, so just don't think, guys, that is classical Guillain-Barré syndrome. So how I have remembered Guillain-Barré, this lesion is bilaterally symmetrical weakness that goes up, ascends up. That is your Guillain-Barré syndrome. And most important subtypes is AIDP, acute inflammatory demyelinating poly. You have also Aman, Amsan, many other subtypes which are not so important. Just see AIDP. Now see, cafe AU spot, leash nodules, that is your iris hematoma. Again a potential MCQ. If you give some quiz, this question definitely come. We have optic glioma, that is neurofibromatous type 1. Okay, so what is the gene? The gene is a myelin gene located on chromosome 17. If you count the number of letters, that is 17. Now see, vascular birthmark, that is by birth, okay, and Port-Weinstein, I think no more confusion, that is your Sturge-Weaver syndrome, that shows you tram track calcification. Again a potential MCQ. Now see, we have renal cell carcinoma, you have hemangioblastoma, okay, you have retinal angioblastoma and pheochromocytoma. I think, guys, if you know, this is very classical. And this question was again, this is again a PYQ. They ask you which one of the following is not associated with your VHL chromosome. So this VHL, okay, VHL is a 3-letter thing. So this is located on the chromosome number 3, and that is P. P is the short arm, petit arm. This is already discussed in my previous video. See, then what are the things that are associated with your VHL, guys? Remember the mnemonic CARPIPS. Okay, C for cerebral hemangioma, okay, R for retinal angioblastoma, R for renal cell carcinoma, P for pheochromocytoma. Do you see, guys? These are the classical things that may ask. This you can leave, guys, not so important. But at least don't forget this first 4. Cerebellar hemangioblastoma, retinal angioblastoma, renal cell carcinoma, and pheochromocytoma. Very important to know. Then see, when someone tells you that is bilateral vestibular schwannoma, I just go to Miss Me-wala syndrome, that is NF type 2, located on chromosome number 22. Okay, gene is schwannomin. Okay, then see, you have hyperdeflection, increase, tone is increased, and Babinski is also present. Okay, that is upper motor neuron ka damage. Okay, so that is, I think, upper motor everything increases, lower motor everything decreases. So reflex also decrease, tone also decrease, muscle atrophy, and there is muscle fasciculation because there is abnormal discharge due to damage, because this lower motor neuron is under the inhibitory control of your upper motor neuron. Now see, coming on to this Friedreich ataxia. So this Friedreich ataxia, okay, again this is a trinucleotide repeat disorder, and here the repeat disorder is GAA. Okay, so in Friedreich you have a staggering gait, you have frequent fall, nystagmus, and diabetes mellitus and hypertrophic cardiomyopathy. So this may be a hint in your clinical question. And there is a trinucleotide. Now see, there is a unilateral facial drooping. Okay, just when the question, so this is a question related to a facial nerve. So this facial nerve, if you see, this facial nerve has a bilateral representation. Okay, in the upper head and lower. So how I have remembered upper motor neuron, okay, and lower motor neuron, we have two things. Okay, so this upper motor neuron is pairs, okay, and this lower motor neuron does not pair because this has a unilateral innervation. Now see, remember the mnemonic VST, V for vertigo, A for oral fullness, okay, S for sensory hearing neural loss, and T for tinnitus, that is your Meniere's disease. This is due to your increased pressure in your endolymphatic sac. So basically aim is to decrease the pressure. So we may try for diuretics, okay, but we won't try for loop diuretic. Why? Because they are ototoxic. So we go for thiazide diuretic, and there is also a role of sodium fluoride in the treatment. Again a potential MCQ that may be asked. Now see, if there is ptosis, drooping, meiosis, constriction, anhidrosis, loss of sweating, okay, and there are two more things, guys, okay, so the mnemonic is ample, anhidrosis, meiosis, ptosis, loss of ciliospinal reflex, okay, and you have anophthalmos. all points towards Horner syndrome, that is your sympathetic ka chain ka involvement. Again a MCQ, this is again a MCQ, this is again a MCQ. So all of these are potential MCQ guys that I have discussing. I have discussed so many PYQs if you look at this HIELTS session. Then see, you have conjugate horizontal gaze ka palsy there, and you have diplopia. So basically this is to the damage to your medial longitudinal fasciculus that leads to your IEO, internuclear ophthalmoplegia. Now see, you have a waxing and waning. So sometimes it increases, sometimes it decreases. Attention is decreased and level of arousal is decreased. So that is basically, that is delirium secondary to some cause. Now coming to your Fanconi syndrome. One we saw Fanconi anemia, where there was increased risk of aplastic anemia, another leukemia wala thing. One is this Fanconi syndrome guys. Okay, so this is basically RTA type 2, renal tubular acidosis type 2. And Fanconi, remember Fan has a gap, so this present with your glucoseuria, amino aciduria and your phosphaturia. Okay, so see, this is renal tubular acidosis type 2. So when you have glucose going in the urine, amino acid going into the urine, protein, so there will be growth retardation, electrolyte ka abnormalities, bone won't grow so well because phosphate is also going down, that is hypophosphatemic rickets. Again a potential MCQ. Now see, nephrotic syndrome guys. Okay, so E for edema, P for proteinuria, H for hypoalbuminemia. See, there is edema, there is proteinuria, and this proteinuria is termed as massive proteinuria, hypoalbuminemia and hypercholesteremia. Again a potential MCQ. And what is the most common cause in child? That is your minimal change disease, MCD. Again MCQ. Now see, if the question suggests you of hereditary nephritis, okay, you have SNHL, sensory neural hearing loss, and anterior lenticonus. Okay, so basically this is your Alport syndrome. So what are the things that we need to remember about Alport syndrome? So Alport syndrome, first of all, okay, this is a type 4 collagen defect. Okay, so this in fact the type 4 of type means this is a type 4 defect, one thing. Okay, and there is Alport, A for Alport, A for anterior lenticonus, and this presents with your basket weave appearance, and this is described as thinning and splitting of GVM, as your classical Robbins write like this. Okay, and see, most of the cases are hereditary, so this is X-linked, more common in boys. Again an important MCQ. Okay, now coming on to the next question that they may ask you, that is your Goodpasture syndrome. So let's finish it this also. So in Goodpasture, remember the mnemonic, you type 1 2 3 4. 1 means this is an example of type 1 RPGN. Good people, 1 2 3 4. Okay, they go very fast. 2 is type 2 hypersensitive. 3 antibodies against alpha 3 of type 4 collagen. Again a potential, and this presents with your typical features of your hematuria and your hemoptysis, that is kidney and lungs involvement. Again a potential MCQ that may be tested. Okay, this is already done. Let's move to the next high-yielding topics. Okay, see, when we talk about your neurotoxic snake guys, okay, so neurotoxic means you have two things guys. Okay, neuro CNS wala things. Okay, so that is C for cobra, and K also sounds like C, that is your crate. Now see, this sea snake, they affect the skeletal muscle, hence these are known as your myotoxic snakes. Viper is basically like a vampire that drinks blood, so this is vasculotoxic. I think this is done. Now seeing your warfarin ka toxicity. Okay, so we know this warfarin ka toxicity guys. Okay, so this warfarin can cause bleeding. Okay, so what does this warfarin do guys? What are the clotting factor that is there guys, that vitamin can activate? That is your 2, 7, 9, 10. Okay, so this activates your extrinsic pathway guys. Okay, so now we need to know how is your extrinsic pathway monitored and how is your intrinsic pathway. Okay, so how I have remembered guys, we have two terms. One is your prothrombin type and one is the activated partial thromboplastin site. So just put a E in between this, that is your prothrombin time is for your extrinsic pathway, and this intrinsic pathway is your APTT wala there. Okay, so this is about your intrinsic pathway. Okay, this is so intrinsic pathway involves, guys, 10. Okay, both of this pathway involves 10, that is 12, 11, 9. Okay, and this involves 7 plus 3, that is again 10. Okay, so see, warfarin is extrinsic pathway, that is PET, prothrombin time. Okay, so this warfarin, this is a classical characteristic. There is a nasal hypoplasia, and vitamin K is the antidote. I'll again discuss. And purple toe syndrome is a rare complication for your warfarin therapy. Okay, so we need to be aware of this complication also, that is your purple toe syndrome. Now coming on to the some other things that may be asked to you guys. Okay, that is your gray baby syndrome. So this gray baby syndrome, that is due to your chloramphenicol exposure. Then you have blue man syndrome. So this blue man syndrome is basically due to your amiodarone wala thing. So we have like so many syndromes like that. So we need to know all the things, guys, that is there, that may come in our exam. So important, like blue man syndrome we have, so purple toe syndrome. So everything, have a look at all the syndrome. Okay, let's revise all the syndrome in one go. 1 minute, guys. Okay, we'll take a new pace. See, if someone asks you gray baby, that is your chloramphenicol. Okay, then coming on to the next one, that is your Reyes syndrome, that is due to the aspirin, that is salicylates. Red man syndrome, that is due to your vancomycin. Okay, then see, then you have your hand foot syndrome. This is again discussed in your anti-cancer drug class, that is your capecitabine or your 5-fluorouracil. Then purple toe syndrome, already done. Again one Mobius syndrome, that is your misoprostol. Okay, so how will you remember? MO, misoprostol, again the same thing. Then you have floppy iris syndrome, one more question. Okay, that is seen in tamsulosin, which is a alpha 1 blocker. So these are all the important syndrome that you need to know. Okay, now moving on to the other important things. Okay, see, this is already done. So coming on to some this midbrain ka stroke syndrome, guys. Okay, so remember like this, guys. We have Weber syndrome. So Weber is third nerve ka palsy. Okay, and we have contralateral hemiplegia. So this occurs basically third nerve palsy, means this will occur in the midline. Okay, and the midline, what is there? You have corticospinal tract. So there will be hemiplegia contralateral. Now paranoid syndrome. So now name only, there is paralysis in accommodation and upward gaze. So this is again a midbrain syndrome. Then Claude syndrome. Okay, so this Claude syndrome, guys. Okay, remember this Claude syndrome is basically a combination of syndrome, that is your North-Nagel syndrome and your Benedict syndrome. So remember what are the things you need to remember about North-Nagel. So see, when we tell about the direction, guys, we write like this: NESW, north, east, west, south. Okay, so this north lies superior, so means that there is superior means above, so there is a lesion in your superior cerebellar peduncle, and this superior cerebellar peduncle connects to the cerebellum. Okay, so there will be ataxia and third nerve palsy plus contralateral ataxia. Now see Benedict. Okay, so this Benedict net can be made to a red. So red nucleus is affected and you have the presence of tremor, again important. And this Cloud is a combination syndrome. So both red nucleus and the superior peduncle will be affected, again a potential MCQ. Guys, you can have a look this. Paranoid syndrome, there is paralysis in accommodation and upward gaze. And here you see the presence of Collier sign, again a potential MCQ. Then Claude, guys. Okay, so you have a combination, that is red nucleus plus tremor wala thing. Benedict, again you will have red nucleus ka involvement, corticosteroid fiber kind. North-Nagel, north is superior, that is superior cerebral peduncle. Weber, that is your contralateral spinal tract, so there will be means contralateral hemiplegia. Wallenberg, this is your lateral medullary syndrome, that is your Wallenberg syndrome. Again Horner syndrome, dysphagia wale symptom, which we have already done. And we have Millard-Gobler and we have Raymond-Fowell. So that is a syndrome of the pons, that is not so important. So you will have contralateral hemiparesis. So mainly the 7th nerve is involved, rarely 6th may be involved. So all these are potential MCQ. Now moving on to the next one. Okay, so if there is Wilms tumor, okay, macroglossia, large tongue, then organomegaly, So and the big baby, okay, that is Beckwith Widman syndrome, that is due to WT2 mutation. So we have Wilms tumor, whether first it may be due to Vagar, W for Wilms tumor, A for NADD, G for genital anomalies, and R for retardation. It may be due to your Beckwith Widman syndrome also. Okay, so this is important that we know. And here the classical thing, that is your hemihypertrophy of limbs, and you have the presence of your omphalocele. Okay, so we have two terms. Okay, one is your omphalocele and one is your gastrochisis. Okay, so we always get confused which is omphalocele and which is gastrochisis. So if this is covered by a membrane, guys, okay, so if it is covered by a membrane, that is your omphalocele, and if it is not covered by a membrane, that is your gastrochisis. Just remember, see, if you see streak ovaries, horseshoe kidney, I think this gives your classical, and the classical, that is short stature, web neck, cystic hygroma, I think no more confusion. Then coming to your Meek syndrome, okay, so that is your ovarian ka fibroma, ascites, and your pleural effusion. Again, an important MCQ. Now see, you have a red itchy swollen rash of the nipple areola, that is your Paget's disease of the breast, suggest of underlying neoplasia, and here you see the Paget cells. Now see, there is a deposition of fibrous plaques in the penis, okay, tunica albuginea, so that is your Peyronie's disease, which is a connective tissue disorder. Then see, you have hypoxemia, decreased oxygen, polycythemia, hypercapnia, that is your blue blotter का syndrome, that is chronic bronchitis. Pink complexion है and hyperventilation, that is pink puffer वाला syndrome. So example, emphysema. So we have one deficiency that is known as the alpha 1 antitrypsin deficiency. Okay, so we need to know, okay, see, this alpha 1 antitrypsin, this is the normal gene, PIMM. Okay, when you eat pizza everyone like, but this is abnormal, so this is the abnormal gene accumulation, and this alpha 1 antitrypsin, this causes your typical pan-acinar emphysema, which is again an important MCQ. Okay, and this affect the lower lobe. Okay, then bilateral hilar lymphadenopathy, uveitis, that is sarcoidosis, which shows the presence of non-chystic granuloma. Okay, this H also means there is Schaumann bodies, and this A means there is asteroid body. Again, both of them are potential MCQ, which may be tested upon. Do not miss it out. Now coming on to the some classical lab finding that may be given in your question, that will help you come to a diagnosis. See, Pseudomonas colonies are there in the lung, and there will be history of child, and there we ask that when mother kissed the child, she felt that the sweat had more amount of salt. Okay, so that is your classical history for cystic fibrosis. What is the diagnostic level? That is your 60. If the sweat chloride is more than 60 milliequivalent, that is your diagnostic for cyst. So there is a defect in CFTR gene mutation located at the delta F508, where there is a mutation of phenylalanine position. Then see, if alpha fetoprotein is decreased, okay, that may be seen in your Down syndrome, Edwards syndrome. Then what are the changes in your Down syndrome, guys? So we have triple marker and we have your quadruple marker. Okay, so what are the things in your quadruple marker? So we have unconjugated estriol, we have your beta SCG, we have your alpha fetoprotein, and we have your inhibin. Here everything is there except for inhibin is not there. So how I have remembered this quadruple. Okay, people quadruple their money when they go to Dubai. Okay, because Dubai gold is slightly cheaper, if you know. Okay, U for unconjugated estriol, B for beta SCG, A for alpha fetoprotein, and I for inhibin. I think that tells you that is Down syndrome. So what are the inhibin? Name only tells high, beta SCG high. Okay, so see, beta SCG is high, and first trimester this PAPA, okay, that is pregnancy associated plasma protein, that is decreased. Vitamin B12, guys, so we will have your increase homocysteine ka level and increase in methyl malonic, like in folic acid will decrease. Drug induced SLE, guys, no confusion, it's antihistone ka antibody. So this may be again your MCQ. Okay, this Down syndrome is again a potential MCQ. This cystic fibrosis is again a potential MCQ. This Beckwith or again one of these potential MCQ. This sarcoidosis again potential MCQ. This alpha 1 antitrypsin and this gene mutation again a potential MCQ. Now see, when you have hypocalcemia and absent thymus, I think no more confusion, guys. This none other than your Dijor syndrome. Okay, that is that is also known as velocardiofacial syndrome, and there is thymic aplasia. This is already discussed in the first part. If you see, then see you have recurrent infection, eczema. So that is TIE, thrombocytopenia, eczema, and infection. So remember TIE, wasp, that is your wasp gene ka defect. Okay, that is Viscott-Aldrich syndrome, WAS. Then there is a large granule, guys, immunodeficiency, and there may be history of your means albinism, that is a Chidiac-Higashi syndrome. So what is there in Chidiac-Higashi syndrome? So this Chidiac-Higashi syndrome, there is a defect in List gene defect. Okay, this is the gene defect, that is a List gene defect, that is like lysosomal trafficking. So there is a presence of cytoplasmic granule, so there is a recurrent infection, that is important, and the patient may present with seizure, gait disturbance, and weakness. Then see, now coming on to optocin sensitive. If you have watched my microbiome division video, I think optocin, who were the OP people, guys? They were alpha hemolytic people, were the OP people. So we have in alpha hemolytic, we have streptococcus pneumonia and we have viridans streptococci. So OP people, okay, where alpha wale people, okay, so that was for pneumonia. P, that is pneumonia, okay, positive, and resistant, that is viridans. R is coming, guys, if you look at it, that is resistant. Okay, viridans streptococci. Then novobiocin, guys. For novobiocin, what was the mnemonic, guys? Novel ESR. Okay, that is epidermidis is sensitive, saprophyticus is resistant. Do you look at it, guys? This is so simple. Now see, coming on to this bacitracin wala thing. So we have this bacitracin, okay, so this group A is positive, okay, and this group B, that is agalactia, that is negative, which causes the mnemonic, this gel wala thing. It causes not the gel wala mnemonic, sorry, this causes meningitis in a child. A classical history, remember, B for baby. Again a potential MCQ that may be tested upon, that we need to know. Okay, now see, you have a branching gram positive rod with sulfur granule, no confusion, guys, that is your actinomyces israeli. Okay, then see, hilar lymphadenopathy, Ghon's focus, okay, that is your mycobacterium bacilli, okay, acid fast bacilli, very simple, 20% acid fast. Okay, thumb sign, that is your epiglottitis. Again a very easy question. Okay, so how can you remember thumbs up, a cold drink, up like a EP, that is your Haemophilus influenza. Then if there is a bacterial covered vaginal epithelial cell, that is your clue cells, Gardnerella vaginalis. Here the pH decreases less than 4.5, and we have the Amsel's criteria, that is positive, and positive whiff test. These are the important things that you need to know. Out of this three, one of them is a very potential MCQ that you need to know. Again, this thumb sign, okay, and the most important, most confusing thing, one is this thumb sign and the other one is your group sign, where it is seen. So this is seen in sorry, guys, okay, sorry. So this group sign, sorry, steeple sign, that is seen in your group, which is also known as your acute laryngotracheobronchitis, ALTB or LTB, we say. So how do you remember it as staple group? I think you won't confuse now. Then bacteria covered with vaginal epithelial cell, already discussed, guys. This is the photo, do you see? This is covered with vaginal epithelial cell all around, if you have a look, guys. So this is your clue cells. Then there is dilated cardiomyopathy, bada things, mega colon, mega esophagus, so everything bada, that is your someone koi to jo chadha diya hai, that is your Chagas disease, and that is due to Trypanosoma cruzi. Again a potential MCQ that may be tested upon. So we need to know about this MCQ, that is your then again the next one. Okay, if we talk about the next one, so that is your, there is a atypical lymphocytes, okay, and you have heterophile antibodies. So when you have heterophile antibodies, guys, I think your directly mind should go towards your infectious mononucleosis, that is Epstein-Barr. And what is the receptor? That is CD21CR2. And what is this name of the cell that I have described, guys? This is your Downey cells. And the typical description is this looks like a ballerina skirt appearance. Again a potential MCQ. When we talk about this Trypanosoma, guys, okay, so remember, guys, okay, we have one is the Trypanosomia brucei, that is known as the East African sleeping sickness. So remember, sun rises in the east, so this rodents is the East African, and sun sets in the west. When it sets, game gets over. That is Trypanosoma brucei. Okay, that is Gambians, that is West African sleeping sickness, and vector is the CC fly. Again a potential MCQ. Now see the next one, guys. Steeple sign. I think we have already done this steeple sign. I think no confusion. Staple crop, that is due to the parainfluenza, also known as laryngotracheobronchitis. Again a potential MCQ. Then see, you have eosinophilic inclusion, okay, in the cerebellar neuron, that is Neckry body, seen in rabies, which is 100% fatal disease. There is presence of hydrophobia. We have two regimen, okay, one is this SN regimen and one is this Thai regimen, if you recall your PSM. So SN regimen 5 letters, so we have 5 doses, that is 0, 3, 7, 14 and 28. This Thai 4 letters, so fourth dose will be omitted. So we have only 4 doses, that is 0, 3, 7, 14 we will omit, fourth dose, and 28. This Thai regimen is the intramuscular 2 dose regimen, guys. This SN regimen is the intramuscular, means 0.5 ml. Here we inject 0.1 ml 2 doses. Again a very important MCQ that you need to know. Now see, when you have a ring enhancing lesion, so that is Toxoplasma gondii or maybe CNS lymphoma. Then Psammoma body, P for papillary carcinoma, S for serous cystadenoma, okay, M for meningioma, M for mesothelioma. Then we have then these are the things about your Psammoma bodies. So the Psammoma bodies, okay, they are a foci of your dystrophic calcification. Then boot shaped heart on X-ray, very easy, that is a tetralogy of Fallot. So what are the 4 components? PROV, P for pulmonary stenosis, R for right ventricular hypertrophy, O for overriding of aorta, V for ventricular hypertrophy, that is right ventricular V for VSD, sorry. Then rib notching on the inferior surface, guys, that is your coarctation of aorta. Again an important MCQ. Then delta wave on ECG, P बार का इंटरवल का शॉर्टनिंग, दैट इज योर वुल्फ पार्किंसन वाइट सिंड्रोम. अगेन दिस हैज बीन डिस्कस इन माय ECG वीडियो इन 50 minutes. Okay, then we have cardiac tamponade. Okay, so there is alternating amplitude on ECG. Okay, and what was the stride, guys? That was your back stride. Okay, what was there in back stride? D wale thing. There was distended neck, vein, decreased BP. Okay, other things like. Then you have granuloma with giant cell after a pharyngeal, that suggests you guys towards the rheumatic fever. And what is the bodies? Ashkoff bodies due to streptococcal wala infection, guys. Then see, empty appearing cells, guys, compared with a cartoon character, it looks like optically clear, that is your orphan any eye nucleus seen in your papillary carcinoma thyroid. Again important. Then this MCQ, guys. This MCQ has been asked like so many times. This boot shaped heart so many times. Psammoma body, which is not an example, so many times. This is steeple sign. So all of these are very favorite MCQ for the examiners, guys. Then brown tumor of the bone. This is seen in hyperparathyroidism or osteitis fibrosa cystica. So basically there is deposition of hemosiderin from the hemorrhage. Then see, hypertension, hypokalemia, decreased potassium and metabolic acidosis, that is seen in your Conn syndrome. Again the classical findings in your question. Then see, there is signet ring cells, guys, that is seen in diffuse gastric carcinoma. Also we have one more, that is your leather bottle appearance, that is seen in your Linitis plastica. And what was this name of this classification? That is your Lawrence classification. Then see, you have celiac disease, guys. So celiac disease, we avoid 4 things, that is barley, rye, oat, wheat. The patient may have diarrhea, weight loss, and the skin manifestation is dermatitis herpetiformis, as the treatment of choice is dapsone. So there is anti-TTG, anti-tissue transglutaminase, anti-gliadin, anti-endomycin antibody. Now see, there is a narrowing of bowel lumen, that is string sign, seen in your Crohn's disease. Lead pipe appearance, that is your ulcerative colitis. So there is C for continuous involvement, O for often rectum involved, L for lead pipe, I for increase in size, everything becomes big. Okay, so these are the things you need to know. Okay, Crohn's disease, the mnemonic is Sister Mac. Then there is thousand of polyp, that is familial FAP, familial adenomatous polyp, that is present on 5q21. Okay, mutation of the APGs, then location is chromosome number 5. Okay, then apple core appearance on barium minima X-ray, that is your colorectal cancer. That in mammary body. So what is the composition? That is CK818. Again, this is a potential MCQ, guys. Like everything that is written is a potential MCQ that may be tested upon. Then you have triglyceride accumulation seen in fatty liver disease. Then see, you have smooth muscle ka antibodies, anti-liver kidney LKM antibody that is seen in an autoimmune hepatitis. Nutmeg appearance, guys, very easy, due to congestive right heart failure. Again, a potential MCQ. Then see, antimitochondrial antibody. Okay, that is seen in your primary biliary cholangitis, PBC. Again, a potential MCQ. So how I have remembered? BB. Okay, that is mother, everything like mother can play, girls can play so many roles. So mitochondrial mother wala means female wala, that is BB. Okay, low serum cytoplasmin, guys. I think this gives your diagnosis, guys. Okay, that is your Wilson's disease. So there is presence of hepatolenticular degeneration, means liver is also involved along with lenticular degeneration in the brain, and there is Kasher-Flesch shedding due to copper accumulation. And what is gene mutation? ATP7B beta 7A in Menkes. Then so you have migrated thrombophlebitis. Okay, that is Strauss syndrome seen in adenocarcinoma of pancreas. Again, a potential MCQ. Then hypersegmented neutrophil means there is more than 5 lobes, guys. Okay, so that is seen in megaloblastic anemia. Again, a potential MCQ. Now coming on to some other hints, guys. Okay, so if there is basophilic nuclear remnant, that is your Howell-Jolly body seen in post-splenectomy. Basophilic stippling in RBC, lead poisoning or sideroblastic anemia. Then microcytic hypochromic, what is the mnemonic? That is SHITA. S for sideroblastic, I for iron deficiency, T for thalassemia, and L for anemia of chronic disease. Okay, here on end or crew cut appearance, guys, this is not specific, but it is commonly seen in two conditions. One is your beta thalassemia and one is the sickle cell, where there is a defect, where is the translation from GAG to GUG. Okay, that is a glutamic acid to lysine. Then there is anti-GP2B3A, guys. Okay, so that may be in immune thrombocytopenia. Also, this is seen in your Glasman thrombocythemia. Then high level of D dimer, guys, that is seen in your DIC, disseminated intravascular coagulation, that is also known as consumptive coagulopathy. Then see, you have giant B cell with prominent outline inclusion, guys. Okay, that is your Reed-Steinberg cells. Okay, so what is the thing that you need to know? That is CD15 and CD30 positive. Again, a potential MCQ. Okay, and we have one more thing, this cytomegalovirus. This is also outside, but here you see basophilic inclusion. This read, remember, E for eosinophilic inclusion. Then see, you have medium sized lymphoid cell with, this is the exact description, guys, they will give you. Scattered tingible body macrophage known as your starry sky appearance, that is seen in your Burkitt's lymphoma. So what are the translocation? That is translocation 2-8, translocation 8 to translocation 8-14. So everything like where you have 8 wala thing, guys, that comes in your Burkitt lymphoma. So Burkitt lymphoma is due to CMYC activation. Again, a potential MCQ, guys. This is again a potential MCQ. Like every question that is here, guys, is a potential MCQ. So there is starry sky appearance, guys. Okay, that is your malignant cells. Then lytic punched out, guys, multiple myeloma, we have dust cells. Okay, and we are Mott cells. These are the cells in your multiple myeloma. Then see, you have monoclonal spike, guys. Again, it is multiple myeloma. So multiple myeloma, it's usually IgG. Don't confuse, multiple myeloma is not IgM ka spike, guys, please. Waldenstrom macroglobulinemia, that is IgM ka spike. And there is one more thing, that is MGUS, monoclonal gammopathy of unknown significance. Then stacks of RBC, guys, that is seen in Rolex formation. Classical question that may be asked. Then see, guys, we have azurophilic peroxidized granules in granulocyte. Okay, so this is OR dots. Okay, this OR dots ka crisscrossing is seen in APML, that is AMLM3, that is known as your faggot cells, seen in acute promyelocytic leukemia. That translocation is translocation 15-17, known as your PML RARA, retinoic acid receptor gene. And treatment is ATRA, all trans retinoic acid. Then see, if you have smudging of the cells, CLL guys, very simple. Tannish racket appearance, okay, and that is Burback granules, Langerhans cell, histocytosis. Again, this all of these questions are the potential MCQ. So bubble appearance, guys, giant cell tumor, osteoclastoma. Again, a MCQ, guys, image based question. If there is a raised periostem such that this creates a Codman triangle, this is osteosarcoma, not commonly seen in Ewing's, guys. Anion skin peeling, that is seen your Ewing sarcoma. So what are the things that the Ewing sarcoma? Remember E for 11, that is translocation 1122. What is the gene mutation, guys? Ewing's, EWS, and wings help you fly, that is FLI1 gene. And what is the marker of this? That is CD99 or your MYC2, which is a marker of your this, and this is a malignant small blue cell tumor. And we have CD95 one marker, guys, can you recall for me? That is the marker of apoptosis, annexin 5 wala thing. Anti-IgG antibody may be seen in a rheumatoid arthritis, that may show classical Bottineer deformity, swan neck deformity. Then this is again important, positively birefringent crystal, then it is pseudo gout. And negatively, this is a frequently confused question, guys, please have a look. So this pseudo gout is due to pyrophosphate or dihydrate, but this is due to the MSU, monosodium urate crystal. Again, this is again a PYQ that has been tested like so many times. Increased uric acid level, guys, gout, hyperuricemia, Lesch-Nyhan syndrome. Can you recall the enzyme defect, guys? That was HGPRT, hypoxanthine guanine phosphoryl ribosyl transferase. And what was the one most important hit? That is self-mutilism. He hurts himself. Tumor lysis syndrome. So tumor will break down, so uric acid will be produced. And loop and thiazide diuretic. What is the mechanism of loop diuretic, guys? This loop diuretic inhibit the sodium potassium 2 chloride channel, and this thiazide diuretic inhibit the sodium chloride channel, Na plus Cl minus channel. Okay, again a potential MCQ. Then see bamboo spine on X-ray. That is your ankylosing spondylitis, and here also we have a Sauber sign, that is positive. And HLA-B27 already done, guys. Recall the mnemonic pair. P for psoriatic, A for ankylosing, I for IBD, R for reactive arthritis. Anti-nuclear antibodies, anti-Smith and or anti-double, that is SLE. SLE is type 3S. Okay. SLE 3 letter. Okay. Then see ANCA. So we have C ANCA and we have P ANCA. So we need to know both. Again, this is a very frequently tested PYQ. So please do not miss it out. So see, C Anka, what I have remembered? I have remembered C class work. Okay, that is seen in Wegener's. And CW. Okay, so from W I have remembered Wipro. That is your PR3. If you do class work, you look like a pro. Then P Anka, that is PMC. M for microscopic cholangitis, C for Churg-Strauss. Let's see, guys. M for microscopic cholangitis, eosinophilic granuloma, PSC primary sclerosing cholangitis. That all are P ANCA. Okay, PR3 wala things are given here, guys. Here they have not included the Wegener's, that is C ANCA. Then see, again important MCQ, anti-centromere antibody, that is your limited scleroderma Class syndrome. Again MCQ, what is Class? C for calcinosis cutis, deposit of calcium. R for Raynaud phenomenon. E for esophageal dysmobility. S for scleroderma. T for telangiectasia, that is the dilated vessel. Now see, anti-topoisomerase, that is your diffuse. So see, anti-centromere, it's located at the center, remember, like this. So when you look at the center, you are focused, that is a limited wala thing. And when you are focused, guys, that is the crest. Okay, you will reach the top height. Okay, then anti-desmoglein, DSG1 antibodies. So we have two things, DSG1, DSG3, guys, if you recall my dermat notes. Okay, so this Pemphigus foliaceus shows basically both of them, this DSG1 and 3. Anti-hemodesmosome antibody, that is your bullous pemphigoid. We have BPAG1, that is also known as 230, and BPAG2, that is also known as your 180. Again a potential MCQ. Then when you have keratin pulse, guys, the classical hint they may give or image based question in is squamous cell carcinoma. There is increase in AFP levels, guys. So that may be spina bifida, dating error, or anencephaly. So like a marker. Then when you have a blue or yellow type, when you're doing a lumbar puncture with the help of a needle, guys, so that is known as the xanthochromasia. That is due to your SAH, which was described as the worst headache of my life in a previous. Eosinophilic cytoplasmic inclusion, that is your Lewy body. Okay, Parkinson disease and Lewy body dementia. Then see, okay, then you have extracellular amyloid deposition in gray matter, that is your Alzheimer's disease. So Alzheimer's disease, this is basically the most common cause of dementia. So basically here we see the presence of neuritic plaques, we have the neurofibrillary tangle. So these neuritic plaques are best seen on your Bielowski stain. Then if there is a depigmentation of neurons in the substantia nigra, that is your Parkinson disease. So there is a decrease in the substantia nigra of the pars compacta, and here the features already done, guys. The protein accumulates forming a tau protein. So tau paths, that is your neurofibrillary tangle, already discussed, guys. Then see, there is a silver staining of tau protein in the neuron, that is your Pick's disease, also known as the frontotemporal, and Pick's disease means personality change, because frontal is involved, which is responsible for personality. Then see, you have a pseudo palisading of the tumor cells, okay, brain may have, that is CNS का thing we need to, and that typically he describes you like serpentine necrosis, and you also have the glomeruloid body seen in your glioblastoma multiforme grade 4 tumor, which has the worst prognosis. Then see, small blue cell surrounding area of neutrophil, guys, that is your Homerite pseudorosette seen in neuroblastoma and medulloblastoma. So this Homerite is a pseudorosette. Okay, then see, if you have a Waxy-Cast with low urine flow, Waxy-Cast, remember, end stage renal disease, chronic renal failure. WCBC cast due to some infection, acute pyelonephritis, transplant rejection. RBC cast means blood is there, that is glomerulonephritis. Then see, anti-GBM antibodies, already done, guys, that is your Goodpasture syndrome. So there is nephritis and hemoptysis, and there is a linear deposition against the basement membrane, and antibodies were against alpha 3 of type 4. Now see, you have cellular crescent, guys, okay. So this cellular crescent, that is seen in your RPGN, rapidly progressive crescentic glomerulonephritis, that is crescent shaped, okay. Again a potential MCQ, this wired loop lesion, this is basically seen in your wired 4 letter, that is type 4 in your lupus nephritis ka classification, that is your diffuse proliferative. Then see, linear deposition of IgG along the glomerular and the alveolar, means both lungs and kidney. Goodpasture done. Lumpy bumpy appearance, guys, that is your PSG and post streptococcal glomerulonephritis due to IgG, IgM and C3. Then see, you have a necrotizing vasculitis or lungs and a necrotizing glomerulonephritis, that is your granulomatous with polyangiitis, okay, that is your Wegener's disease, okay, Wegener's CW, Cianca, and Vipro, okay, Pro, PR3. Do you see? Again important MCQ. Tram track appearance of capillary lobe, okay, when you have a tram track appearance, okay, here a light, so that is your membranoproliferative glomerulonephritis. Again a potential MCQ. Nodular hyaline deposits in the glomeruli, guys, that is seen in your diabetes mellitus case, that is your KW nodule, Schmelzl Wilson nodule. All of this question that you see, guys, this is a PYQ, this is a PYQ, this is like a frequently repeated question. So everything that you see here, guys, this is a PYQ, so please do not miss it out. Anything and everything can come here, whatever I am discussing. Now see, if you have a effacement, so minimal changes, means there is no change in light microscopy wala thing. So child with nephritic syndrome, most common cause of nephritic syndrome in child, minimal changes. See, there is a spike, so spike and dome appearance, that appears at the peak of their life, so that is your membranous nephropathy, again seen in this is again a nephrotic syndrome. Now see, if there is a thyroid like premise, there is a thyroidization of the tubule, that is chronic pyelonephritis, again a frequently tested MCQ. Granular cast in urine, that is seen in ATN, which may be either ischemic type or maybe the toxin type. SCG is elevated, guys, that is hydatidiform mole. If there are multifetal gestation mode, twins are there, so more SCG will be formed. Choriocarcinoma and beta SCG was ironed down in the quadruple test. Then see, if there is a racenoid nucleus and hyperchromism, they describe it like a coilocyte. So they are seen in human papilloma virus. So we have low risk, that is 611, and we have high risk, that is your 1618. Again a potential MCQ. Then you have seeds of uniform blank cell, that are fried egg appearance. SCC in increase LDS seminoma, male counterpart is your means seminoma in male, dysseminoma. So what are the new tumor markers? That is OCT3, OCT4 and NANOCT2. Please learn it. Then see, you have glomerulus like structure in a vessel of germ cell, so that is your ciliate dual body seen in your York sac tumor. So York sac tumor, what are the things we need to remember? Remember YES. This York sac tumor, also known as the endodermal sinus tumor, and shows the presence of ciliate dual body. Then see, there is a descendants granulosa cells. Okay, so they ask what is the body collection. So remember, call the granny. So that is your call external body, again a potential MCQ that may be tested upon. Then chocolate cyst of the ovary, everyone knows that is your endometriosis, frequently is bilateral. Then mammary gland with the blue dome cyst, that is a fibrocystic change of the breast. Then do you have a Leydig cells with crystal like deposition, guys? See, look at the images, guys. Okay, this is the axonal body. So what happened, there is a amorphous pass positive material, guys. Okay, and this there is a coffee bean nuclei. So there are two things that shows coffee bean nuclei. So remember the mnemonic, brew the coffee grain. So okay, so this one is the Brenner's tumor, another is your granulosa cell tumor. Okay, so this is your granulosa cell tumor, which shows your call axonal body, call the granulosa cell tumor. Okay, now coming on to the next one, that is this one, guys. Do you see this appears like a glomerulus? Okay, glomerulus like appearance. Okay, there is a row of tumor cells. What is this, guys? This is the glomerulite body known as the Schiller-Duval body. So this is seen in yes mnemonic, York sac tumor. Again a potential MCQ that may be tested upon. Okay, and this is the clear white space. See, this is basically what, this is the basically the crystal, hence Ringkes crystalloid seen in Leydig cell tumor. Do you see the crystals? Then see, here we have two things. One is the nest of the tumor cells, and one, if you look it out, guys, this is your coffee bean nuclei. So coffee bean was the two place. One was the Brenner, one is the Brenner's, one is the granulosa. So this is the Brenner. How will you remember? Remember Brenner 2N. One is for the nest, that is Walther nest. One is for nuclei, that is coffee bean nuclei. Now look, this is the classical appearance, that this is the teratoma appearance. So basically you can have cartilage, bone, everything can be present, guys. Okay, so this is teratoma, and this is your Rokitansky protuberance. Again a potential MCQ that may be tested. Now this seminoma in testis and this germinoma in female. So guys, when you look at the photo, so you have a fried egg appearance of the cell. Okay, and you have a sheets of tumor cells which are separated by your fibrous septa, which has lymphocytic infiltrate within them. Again a potential MCQ. Now see, if you have a thrombi made of white and red layer, that is your lines of Zahn. Okay, which is seen in arterial thrombus. Again a potential MCQ. Out of this, one question is pakka, guys. Okay, so see, you have now needle like crystals in the bronchial secretion. So when you look at bronchial secretion, you have three things, guys, you have to know. One is the Charcot-Leyden crystal, one is your Crushman spirals. Okay, so Charcot-Leyden crystals, and you have when you have your this desquamated cells, okay, that are your Crushman spiral wala thing. Okay, these are the things that you need to know for your asthma. And what so this Crushman spiral appears something like this, and this is the Charcot-Leyden crystal, that is your eosinophilic conclusion. And also we have one more thing I am forget to name, but that is made of alpha galactine, guys. Please have a look at it, guys. Again important that you need to know. Okay, you cannot miss it out. So revise it, guys, when you are revising this asthma. One is the Charcot-Leyden, one is the Crushman spiral, and one more, sorry, I am not able to recall it now. Okay, then see, honeycomb appearance on CT, that is seen in idiopathic pulmonary fibrosis. Iron containing nodules, guys, that is your ferruginous body or asbestosis body, and this asbestosis affect the base. Okay, again an important PYQ, please do not miss it out. Now see, if you have a apical tumor, okay, upper lobe is involved, so basically that is your Pancoast tumor. So this will compress the apex of the lung. So this is again a potential MCQ that may be tested upon. So this also we need to know. Please do not miss it out. So okay, this is important. Then what are the important things? See, this is a table that shows everything about your ovarian tumor, the questions that are frequently asked on ovarian tumor. So things we need to know. So call axonal body, guys, recall with me. Call axonal body seen in granulosa, call granny. Coffee bean, we have two things. One is your granulosa cell tumor, and brew the coffee, that is your Brenner's tumor. Then see, this Sheila duval, also known as the endosymal or glomeruloid body, seen in York sac tumor. Then see, this Rinke's crystal seen in Hylas cell tumor. Samoma body seen in Sirius tumor. Walthat cell nest and Brenner's tumor. Signet ring cell, Krukenberg tumor, that is bilateral from colon or GIT wala thing. Hobnell cell, okay, that is a clear cell cancer, okay, that is associated with diethyl isbilstrol exposure, again a potential MCQ. Then you have a polygonal with fibrous septa, that is dysgerminoma. And when you have skin, teeth, cartilage, everything guys, that is teratoma, that is Rokitansky protuberance. All these images are also done guys. I think hope this helps you revise the most important high-yielding things that are expected in your exam. So these are all the favorite question that may be asked you. So I think this helps you recalling, help you in recall of your BTR or your MTR. Mujhe to Rato session part 2. If you like it, please comment, subscribe, and like the channel and share with your friends too. We'll be soon back with the part 3. Happy learning guys.